Yeah, Pawan, we can start the slides now. So I welcome you all once again. This is the 38th edition of Thursday Musings. We have been running strong since the first lockdown. I think we'll enter the second lockdown with the Thursday Musings coming, going along. Next slide, please. Yeah, let me welcome the chief of the program, Professor Pawan. And since he does not like his introduction to be read, I just hand over to him.
Thank you.
Sir,
thank you, Dr. Aleem. And I welcome Dr. Aleem and Dr. Amrit as moderator of this program. Dr. Amrit Patjoshi, who is the chief consultant neuropsychiatrist in Amri Hospital and Healing Touch Clinic, and professor of psychiatry in High Tech Medical College along with me. He's a direct council member of Indian Psychiatric Society and editor of Odisha Journal of Psychiatry, which has been indexed. And he had been the chief coordinator of UNICEF WHO IPS initiative on telemedicine last year. And with this, I welcome Amrit. He has been welcomed in the beginning also. And I have with us Dr. Aleem Siddiqui of Lucknow ka Nawab. He is the director of Healthy Minds Neuropsychiatry and Behavioral Science Center. He is visiting professor of psychiatry at Lucknow Medical College Hospital. He is past direct council member, IPS, and he is guest faculty of Amity University, Lucknow, and finance secretary of IMA, Lucknow, and IAPP UK chapter. Welcome, Aleem. And I have the pleasure of introducing Dr. Ashwin Mohan Chandigarh, who is keenly involved in addiction psychiatry. He has completed his MD in psychiatry from PGI in the year 2000. He has done his PGD MLE from National Law School in Bangalore in the year 2016. He is a senior practitioner in Chandigarh, having his own establishment. His major areas of interest are addiction psychiatry, forensic psychiatry, mental health policy and law, and advocacy. He is currently an EC member of IAPP, EC member of APSI, co-chairman of IPS Addiction Psychiatry Specialty Section. Welcome, Dr. Ashwin. And we have with us Dr. Sanjam Gajendra Singh Gajendra Imphal, who is associate professor in the Department of Psychiatry and assistant nodal officer, regional drug treatment clinic in the Department of Psychiatry, RIMS Imphal. Published more than 40 scientific articles in national and international index journals. Awarded National Best Presidential IAM State Secretary Award in 2012 at IMAC and 2012 at Kanyakumari. And we have got two chairpersons from both the North Corners of India, which is infamous for drug addiction problems and challenges how to manage them. They can contribute and they can have their views. And with this, I hand over the meeting to Dr. Mohan and Dr. Singh. Over to you, please.
Thank you, sir. So I thank the organizers for inviting me as the chairperson for today's important session. It gives me great pleasure, and it's an honor and privilege actually to be chairing a session by one of the doyens of addiction psychiatry in India, Dr. Pratima Murthy. She's a teacher, a researcher, and a clinician par excellence, and she has trained thousands and thousands of people in the scientific basis of addiction. And it's always a pleasure to listen to her. She's an excellent orator, and I'm sure she will deal with this very, very difficult topic, because the truth is most large number of practitioners and clinicians really do not want to deal with patients of addiction, and that is the sad truth. It's because of the profile of the patients, the kind of problems that they come with, the repeated relapses, and the stigma and discrimination and underlying moral issues which are always associated with addiction. And so all of these combined factors make the treatment of a patient of addiction extremely, extremely difficult, especially in day-to-day practice. And of course, to mention the element of therapeutic nihilism which creeps in after years of treating such patients, when इसे कुछ नहीं हो सकता and आपका तो तुम्हारा तो कुछ नहीं हो सकता. So ma'am is going to deal with this very important issue of challenges of treatment of addiction. Without wasting more time, I would hand over, although she needs no formal introduction, but we need to complete the formalities, and I will hand over to Dr. Gajendra Singh, who I'll request him to please introduce ma'am, and then she will start the proceedings. Thank you, everyone.
Thank you, Dr. Singh. I think ma'am doesn't need any introduction. When I was a student, since then I'm very fan of ma'am. I attended many lectures, many conferences where I attended ma'am's lecture, and she's a gem of a person, one of the most renowned psychiatrists along with addiction specialists in the country and abroad. So just from an introduction, she's the head of the Department of Psychiatry, NIMHANS, Bengaluru. She was earlier headed the Center for Addiction Medicine. She's one of the best clinician, trainer, and researcher, primarily in addiction and mental health. She has a special interest in treatment and outcome in addictive disorders. She has edited several manuals on addiction treatment and management. She is an international trainer for the WHO, UNODC, ILO in tobacco, alcohol, and other drug cessation programs. She is involved in AMP cessation and quitline initiatives for tobacco, virtual training through the ECO, as well as postgraduate training and research in these areas. With this little introduction, I request ma'am to start the presentation.
Thank you very much, Dr. Singh, for that introduction. Thank you, Dr. Ashwin. Let me first congratulate Dr. Topan Thati, Dr. Aleem, and Dr. Amrit on 37 successful programs of this kind. I think these are very interesting initiatives to begin, but they are very difficult to sustain. So my warm congratulations and all good wishes for many more such series. I've always been amused by the fact that these are called Thursday Musics. In fact, just last week, I've written a small middle in the Deccan Herald called Webinar Wars. While I'm a great proponent of technology, I also find that, you know, we're working during the day and then we're working in the evenings. And I realize that the most troublesome phases, the most irritating phases are, can you hear me? Am I audible? So I very deliberately do not ask these questions because they are grating to the ears. Nevertheless, I think COVID has provided us an opportunity to listen to each other, to learn from each other. And since it was called Thursday Musings, I thought it's very important to really reflect on the area of addiction. In some ways, take you through a personalized journey. And therefore, in the process of doing this, I realized that I thought I would not be using slides. I think slides make it less of a musing and less of a reflection and, too technical. So I hope that I'll be able to, in the course of the next half an hour, not only talk about some of the challenges that we face in practice, but really take you through what a professional career in addiction involves. And in some ways, take you through my own journey through this process. I remember Vishal Indla had, I think a few years ago, produced a small book on careers in psychiatry and had asked me to write something on addiction psychiatry. And I had actually asked one of my postgraduates, who's now a faculty, on what he thought, was a career in addiction medicine. And he put it so beautifully and said, I think those of us who work in the area of addiction are addicted to addiction treatment. And I believe that's something that's really helped us, despite the kind of things that Ashwin Mohan mentioned about therapeutic nihilism. It's really shown us how valuable it is to work in the area of addiction, how valuable people with addiction-related problems are, minus their addiction. The journey began, of course, when I was a postgraduate and I decided to do my thesis in the area of addiction. I remember Dr. Rajat Ray, who I'm sure all of you know very well. He's a mentor to many people. And Dr. Ray asked me, why did I want to do a thesis in addiction? So I told him, you know, having done my undergraduation in medicine and being fascinated with internal medicine, this I thought was closest to internal medicine. And then he had a loud laugh, ha ha ha, you know, saying that, you know, how far removed, you know, what your thinking is, you know, in terms of when you deal with addiction, there are so many other facets to it. It's not just medicine. Of course, in the next 2 or 3 decades, I learned a lot about the other facets of addiction, but now I believe I've come a full circle. And I know that a very good knowledge of medicine, being a good physician, is very important, not just to be a good psychiatrist, but especially to work in the area of addiction medicine. And that's very important to understand. So there was a lot of inspiration when I started my post-graduation. I remember my thesis was on erythrocyte aldehyde dehydrogenase and alcoholism. Again, a very biological topic. And I'm going to come back to this in a little while. So although I began my career in the biology of addiction, you know, way back in the late 80s, subsequently, of course, the large body of my work has been in looking at psychosocial interventions in addiction. A large part of, I'm first going to talk about some of the formative work in the area and then come back to the clinical challenges, because I think it's very important, you know, to get almost a 360-degree view of this area if one is not to be overcome and defeated by the challenges and come out of therapeutic nihilism to really understand how one can help patients. So I have to actually acknowledge the role of the UNODC. It was called the UNDCP then, the United Nations Office on Drugs and Crime now, drug control program earlier. And for almost 2 or 3 decades, I worked, like indeed several other people in the area, working on various aspects of very basic things. How do you identify a person with addiction? How do you assess a person with addiction in a comprehensive manner? How assessment is actually a part of the management, because when you're asking for the details, you're already getting many indications of the problem the person has and the likely approaches that might help the person in management of the addiction. Of course, Ashwin mentioned how to prevent relapse, and that was a very important thing. What do you do when a person overdoses? And overdoses actually have become a huge problem. And I think it's a huge challenge to many people working in the area of addiction, not just psychiatrists. There are a lot of physicians who work in emergencies who, you know, probably deal with the brunt of this. And again, I'll give you an anecdote on how important this is. How to respond to crises, because many people with addiction do have huge crises in their lives, and you need to be available to them when such crises occur. The terminologies in addiction. I mean, I think one of the things that probably when we were training is to call, you know, refer to people as alcoholics or addicts. But we now know that these are persons with addiction, persons with alcohol dependence, and so on. So in some ways, we have learned to destigmatize our patients, because I think that's one very important way of getting them engaged when you remove the stigma from, you know, from this whole problem. The other thing I think we've also, I developed programs for intervention for families. Families are so distressed, so emotionally drained, so desperate that they need full support. And it's a very legitimate need that you cannot ignore families. And then it was about working in the community, because alcohol is more than just an individual problem. Addiction is more than just an individual problem. It's a problem of the family. It's a problem of the community. So it's all, if you really want to work in the area beyond the clinic, you've got to look in the community. And that was where I did quite a bit of work with the International Labour Organization. And one of the simple approaches of the International Labour Organization is the traffic light model, that you can classify people in the community in a green zone, in an orange zone, or in a red zone. Unfortunately, as clinicians, we focus only on the red zone, which is people with very, very severe addictions, where relapse is almost the rule, where the inputs are very intensive, but the outcome may not be that rewarding. And because our experience is only colored by this group of people, we tend to kind of generalize all aspects of addiction as not being able to be, reversed. And that's why it's important, of course. I mean, there's no way we can get out of the responsibility of treating people with, who are in the red zone. But I think it's very important to also focus our attention on not allowing people to get in the red zone. And that is the way you do that is by approaching people in the orange zone, people who are developing problems early, people who have associated comorbidities, people who are still motivated to change and whom you can easily kind of inform and get them screened and tell them how important it is. And my own belief is that nowadays we are getting more and more people coming to the clinic, not just in the red zone, but in the amber zone as well. And in the green zone, you have people who either, are not using the substance at all, or who might be occasional users, but then they are fairly well protected. They are not at risk. So the general approach or the philosophy of the International Labour Organization is to keep the greens green. And one of the challenges is really, what are the protective factors that prevent people from going towards substance use and addiction? And for all of us, I think it's very, very important to recognize what those things are, what are the risks, and therefore help people with those risks. And then, of course, you try and get the red zone people into the amber zone or the green zone. The amber zone people, you self-motivate, you get them to learn how to recognize a problem that they're having and teach them some skills of getting out of the amber zone into the green zone. In the next phase of my work with the International Labour Organization, we focused on workplace prevention. And that was extremely exciting in the 90s because there was no concept of workplace policies on addiction. What do you do? We all know that addiction, as we mentioned, I mean, in so many states, it's almost epidemic proportions. And addiction causes in the workplace, absenteeism, accidents, loss of productivity, increasing health costs, and what have you. Therefore, the Karnataka State Road Transport Organization, which was one of the largest transport companies in the world, it was said that 1 in 7 commuters on a bus rode on a KSRTC bus. So that was a very exciting program that we developed, where we really got the employees in the KSRTC, drivers, conductors, etc., engaged in an addiction treatment program. We didn't just do that. When they went back to their workplaces, we made sure there was a follow-up, and we showed what a dramatic change there can be when there is a group of people who is monitoring them, supporting them, catching them if there is a lapse, and making sure that the lapse does not turn into a relapse. And that was really very, very rewarding. And the findings of that study showed us that people would not only recover their health, their economic condition could improve, their family lives could improve. So in the 5-year follow-up of the KSRTC, we went back to their families. In fact, it was quite shocking that many families did not even know what their spouse earned. The effect of the addiction program was equally amazing. We had people who came to the KSRTC vigilance officer. He was a Mr. Sri Kumar then, he was an IPS officer. They came back, fell at his feet and said, look, before this program started, I had run into lakhs of rupees as loans. And after this program happened, I've actually saved enough to buy a scooter or a plot of land or put my child in a good educational institution and so on. So it was very, very gratifying, this program, because it really helped us to get a sense of a community and how you can actually make changes if you develop a comprehensive program in the community. Of course, another person I must recall in terms of the multidisciplinary work is Lakshmi Shankaran, who works in the Banyan. Again, has a very good insight into the understanding of the psychosocial consequences and the need to work in the community. one cannot simply forget the work of Dr. Shanti Ranganathan. And Shanti has been a great inspiration all along in terms of just her selfless work with patients who have addiction. And I mean, Shanti has contributed hugely, and there's a lot you can learn from her in terms of meeting some of the challenges, including personal challenges when you come with addiction. Another very important thing I have realized is the relationship with the patients. Just as therapeutic nihilism can destroy any kind of relationship and positivity that you can bring out of treatment, it's very important for your patients to have trust in you and to establish a therapeutic alliance with patients. Through therapeutic alliance, you may not be able to change everything to the best of everybody's satisfaction, but you can certainly move your patient or client in the direction of change. And every time the person, I say it's like slipping on a banana peel. If something happens, you kind of have a problem. It is the support of treatment which helps you from falling completely flat. You may trip, but you can pick yourself up again and carry on in your journey of recovery. So I think that's something very, very important as far as patients are concerned. Consolidating this work that had happened in the last, the previous 2 or 3 decades, and I think all of us have realized where we work at NIMHANS the importance of team building. And I think having a team of professionals who watch each other's back, who help to resolve problems and challenges when we come across difficult patients has been really, really wonderful. And I think that's one way of really overcoming challenges. And I think, for example, groups like this, where we discuss, maybe difficult situations, the platforms like the ECHO, the digital training platforms, where you bring in difficult cases and together work out what might be solutions. These are extremely important in reducing the therapeutic nihilism to some extent and trying to find solutions. I mean, I think nobody can kind of fool themselves into believing the treatment of addiction is easy business. It's tough, it's rough, but the fruits of that success, however limited they are extremely sweet because the relationship kind of carries through to life. And once the person is separated from the addiction, they are some of the most wonderful people to have a therapeutic relationship with. Many of my colleagues have again been very, very inspirational in this area. I must mention my colleagues. There's Dr. Vivek Benegal, who has an interest in looking at risk factors which determine substance use in later life, has done a lot of work in this area, looking at externalizing symptoms and their relationship. There is Prabhat, who has revolutionized the training in terms of the ECHO. There is Arun, who has an interest in substance use comorbidity and in adolescent drug use. I have 2 very young colleagues, Lekhansh and Jayant, who are the first DMs from our institution. And I think having young people come in is tremendously enriching. And I think what it does is that it's almost like a continuing professional education when you actually, discuss things with your peers, because that again brings a totally different perspective to the way you look at things. I have a rather conventional way of looking at things. And when I listen to colleagues who have a different point of view, I think it really helps, especially in the individual management of patients, because each patient is so challenging and so different from each other. These kind of experiences all help. Similarly, I've had colleagues who are psychologists, psychiatric social workers, psychiatric nurses, who bring in their perspectives. And I think this multidimensional approach to addiction management is very, very important in overcoming many of the challenges that come through. And especially people who take an academic interest like PhDs and DMs are extremely valuable in this journey, because they help you to look at certain aspects of people which you might not be completely able to in a clinical setup. So for example, there was this young PhD scholar who looked at young people in colleges and what they needed in terms of possible helping to reduce the risk for substance abuse. And these were very, very simple things, which, intuitively you might have known. But his, establishing the fact that people are looking for, support in their relationships, are looking for good time management, or looking for coping skills to deal with emotional problems. These are the kind of things that really help you to plan services for these groups in a bit of a structured manner. So I think I'd just like to say that multidisciplinary teams are extremely important. I've always been interested in treatment and outcome, and therefore looking at both pharmacological treatments as well as psychosocial treatments, following up patients has been an interest. And in following up patients, one of the biggest lessons I have learned is if you just see patients in your clinic, you do not follow them up, the chances of relapses are as high as 80 to 90% in a year. You organize a proper follow-up program, make sure the patients are called, and when they are called, if they happen to have had a lapse or relapse, tell them it's okay, just come back and discuss what happened. You can actually improve the outcomes and keep almost 60 to 70% of people in your treatment loop. Again, it's not magical, but just imagine if you could reduce your attrition from 90% to just 20% or 30%. It's amazing. And why is it amazing? Because if you keep people in the treatment loop, the chance of their improving also improves over time. So most people tend to drop out between 3 to 6 months, even more between 6 to 9 months, and practically everybody between 9 to 12 months. But if you keep them in the treatment loop, the chance of their working on their problems over time is really, really huge. And we've actually demonstrated that in studies. So now we actually have follow-up counselors who will call the patients. And patients have come back with tears in their eyes and said, oh my God, I would never have come back because I had relapsed. I was ashamed to show my face to you, doctor. After all the trouble that you all took, it was when that person called and comforted me and said, it's okay, I decided to come back and try and work at my problem again. So that's how important it is to have follow-up and aftercare. The second thing is the expectations from treatment. Patients have different expectations, families have different expectations, and as professionals, we have our own expectations. And very often for us, as well as for families, the expectation is abstinence. For the patient, it may be eventual abstinence, but the journey to that may not be very easy. Remember, there have been very often when people come to us, they come years and years and years of substance use, and making those lifestyle changes is not easy. So I think really making the expectations around reducing problems, working on relationships, rather than only abstinence sometimes works. I mean, I still advocate abstinence to all my patients, but I am perhaps over time more accepting if they are not completely able to, follow up, to have abstinence 24/7, 365 days in a year. So you learn to accept a reduction, sometimes a 50% reduction or a 40% reduction, with reduced problems, with better functioning at work, gradually understanding that they can work on their substance use, and doing this in a progressive manner is important. So it cannot be done bang at one go or at one sitting. But if you continue to work with the patients, you can definitely demonstrate change over time. The other thing that, of course, that you learn is the biology versus the environment. All of us know that there's been a lot of work on the genetics of addiction, and we know that 60% of the variance is explained by biology, and maybe another 50, 40 or 40% or 45% by environment. One of the things that can happen is if you focus too much on the genetic risk, is that the onus of responsibility of change is flatly put on something else. I have a genetic problem, I can't help it. And that is why it's very important, even recognizing that the person is at a biologically vulnerable situation, that they have the ability or the capacity to change. And we know now that there is flexibility of neuronal networks and the way they kind of synapse and create networks with each other. So why can people not have the ability to change? So this focus on the ability of people to help themselves, to get support and to change is something very, very important. And that's important to understand in the background of the understanding that addiction is a biological problem and is a brain disease. I think the lot of publicity as to why addiction was called a brain disease is because of the stigma associated with addiction. People, it was, if you consider it as completely under control of the self, which it's not, which it's really not, then there's a huge burden placed on the individual. So recognizing that there are brain changes, recognizing that there are neurochemical changes is very, very important to understand that the person is vulnerable, they lack control, and the addiction is getting the better of them. And explaining that to patients, and most importantly, their families, helps to engage people better. So that you can look at ways in which you can actually help the person to move along, again, in a progressive manner. The second important thing is to move beyond addiction, to look at the underlying risk factors. And we now know that temperamental factors, broken homes, impoverishing environments, availability of alcohol and other drugs, accessibility to drugs, a whole range of issues can drive people towards addiction. The second thing is that mental health problems are very, very common drivers of addiction and concurrently present with addiction. And that is why, as we mentioned in the beginning, Dr. Tufan Bhatia had this beautiful screen behind him with all the drugs. And I think that is why psychiatrists are best positioned to deal with addiction, because of the co-occurrence of several kinds of psychiatric issues around it. We need to be able to look beyond the addiction, to look at underlying mental health conditions, underlying temperamental issues, of course, and later in life personality issues, which may be maintaining the substance use. So it's not enough just to take the drug out of the person. You also need to help the person to deal with these kind of difficulties in their mood, in their temperament, in their perception, in their relationships, and so on. That's very important. And towards that, the patients have been my best teachers. I think if you sit down carefully, I think time is very, very important. Spending quality time with patients is extremely important. Trying to understand what makes them, what drives them into the addiction, what maintains the addiction. Once you've understood that, once you're able to help them to work with that, then you can help them to change. And all of us know about the non-specific factors in psychotherapy. And I can't emphasize how important these non-specific factors are to help patients with addiction, because acceptance, warmth, unconditional positive regard are extremely important to help patients to want to change. So one of our biggest challenges is to make patients want to change their conditions as they are now. So why are patients reluctant to come to us? We keep saying they don't want to change, but there are lots of other factors that underlie this reluctance to come. One, of course, is something that I mentioned, is the shame of, being called an addict or an alcoholic. So they already been shamed. They don't want to face more shame. They're afraid that if the substance is taken out, how will they cope? How will they manage? So it's very often driven by anxiety or fear about how they're going to be able to change. And the third is often an anger, because there are difficulties in relationships. There may be difficulties in the various kinds of situations that they're faced in. So these are the drivers. The other thing, of course, is a difficulty in anger management that many people with addiction also have, which is something that comes to the fore and prevents their getting treatment. So engagement is possibly one of the biggest challenges. Very often people may be brought reluctantly by their family members. They have not considered change at all. All of you know Prochaska and Diclement's stages of motivation. So they're in their pre-contemplation, they've never considered it. And then one of the things that we do is actually talk to the patient first. The reason we do that is if you allow the family also to come in, the family is just so full of ennui, so full of distress that they would be bombarding, in the patient's presence, the criticism of how the patient has behaved, how terrible it has been, and so on. Instead, allowing the person to talk about themselves, it doesn't have to be about addiction, but giving a person a chance to talk about themselves, to talk about what they want to, where they see themselves in the future, what they think they can change about themselves, what is it that they need help with. Very often, that is a significant locus of getting them to want to change. And then, of course, you may want to listen to the family, and very often having a joint session where you listen to the family, but you allow the patient to convey their own side of the story is also equally important. I talked about the motivation, the stages of motivation, and really that is exactly what we do. We try and move patients from a stage of pre-contemplation to a stage of contemplation, determination, action, warn them about relapses, and when they come back, we help them with their relapses. Expectations of family members have to be dealt with, but they have to be dealt with in some way separately from the patient, because the patient is the primary person that we would like to help and move along, and therefore supporting the family, supporting the issues that they might have is also important, but done differently than with just the patient. Preventing relapses is the biggest challenge, and the way we do that is to keep in contact, be accepting of patients who might relapse, or following them up. And I've already told you. Now, unwilling patients are a big problem with addiction, in addiction treatment. At the same time, I think one should understand that there are unwilling patients for everything. And Thomas McClellan puts it very well in a set of seminal articles. He said, look, the kind of follow-up and recidivism in diabetes and hypertension and addiction is much the same. But in addiction, we kind of hit ourselves, blame the patient for a lack of success. So I think when people are unwilling, we need to look at strategies. We work with families trying to see how is it that they can come? Is there somebody who is an opinion maker, an influencer who can bring them in? Can you wait for a problem to occur and then bring them in? Can an employer help to bring them in for treatment? Because once the person comes, then you can work at the engagement. The biggest problem is that patients don't come to you. I still remember the importance of working with families. There was this young man from Kashmir who came in. He had overdosed with a combination of benzos and opioids about 3 to 4 times. His mother moved from Kashmir to Bangalore so that she could stay with him. She was a very successful academic, gave up her job, came and stayed with him. They learned that if there was a threat of an overdose, that they need to take him to the nearest hospital possible. And believe you me, twice the boy was on a ventilator because he had overdosed. The family learned how to manage that emergency. Now, he then successfully went to the UK, completed his training in psychology, has come back to India, is married, has a stable job, and is doing very well. This is a boy who would have died in his early 20s had the kind of arrangements not been in place. So it's not just what we do, but we also need to get the family to understand what are the support systems and networks need to be in place so that if there is a crisis, others can handle it as well. The other thing, of course, coming to the networking issue, we have to network. Substance use is associated with not just with psychiatric comorbidities, but a lot of medical comorbidities as well. So we have to network with our physician friends. Remember, I told you our physician friends are likely to, meet with overdoses, etc., in their own emergency setups. We need to make sure that when such overdoses happen, when they are effectively treated, that the patient is counseled. And that is very important. For example, we get a lot of delirium tremens in our hospital. Very often the approach is to treat the delirium, tell the person not to drink and send them home. But it's only when you admit these patients, do a detailed evaluation, after their cognitive functions have improved a little, motivate them, and then work with them and their families, both through pharmacotherapeutic and psychosocial interventions, then you actually see the 1 month outcomes are far better than if you just sent them off with the treatment of their delirium. We recognize that substance use is a risk factor for a variety of communicable diseases and non-communicable diseases. So now we are working with physicians to help them to address risk factors, to counsel patients. So that kind of counseling is not just, need not be done by us, can be done by other physicians working in the general hospital setting. And they need to be escalated to us if there is a problem that they cannot handle. So moving from a clinical setup to a public health setup is equally important. And that's something that we need to work with our fellow professionals to deal with. Finally, I wanted to talk about poor patients who don't have resources, and that's when they really pose a lot of difficulty, because whatever resources they have has gone in the use of alcohol or other drugs, and then they have very, very little to fall back on. So through whether it's a district mental health program or other places, making sure that we can get them some amount of pharmacotherapy to prevent relapses, to deal with withdrawals. But more importantly, psychosocial interventions is something that we all need to work for. I know that most of you may have been concerned about clinical cases that you get, individual problems that you had, but I have deliberately not address some of those things, because I believe that, that would be a case-based discussion. I have tried to focus on how we have met some of the challenges that occur with patients with addiction. The other thing, of course, is, since we were talking about Punjab and we're talking about Manipur, one of the biggest things is of course, opiate addictions and the availability of opioid substitution treatments. Ashwin has done a lot of work on it, and I'm sure he would be able to really tell us the scenario in terms of, the ground realities, in terms of the difficulties in making OST available. We're still struggling. For example, we haven't been able to make methadone available, which is something that we would like to. But I think that those kind of struggles go on. So whether you're working as an individual clinician, whether you're working in an academic institution, in a primary care facility or a tertiary care facility, these are problems that occur all over. So I don't think it's only in a few states. Now the problem of drug abuse is kind of all over. We had the opioid epidemic starting in the Northeast, and then it's kind of spread to many other states. But now what happened with illicit drugs initially, we now have a huge epidemic of pharmaceutical drug abuse. Atul's and his team's work on the epidemiology of drug abuse, we all know that while it's a problem among males, the number of women increasing drugs has increased. We know in terms of adolescent use, inhalant use in adolescents actually more than with adults. We know a lot of newer drugs like synthetic cannabinoids, other kind of stimulants have entered the market. We know people use a whole lot of other drugs, whether it's appetite suppressants or whether it's bodybuilding agents. We're starting to see people who can pre-COVID, because I think COVID gyms are closed down. We used to go to gyms and get huge amount of steroids and come with a steroid rage. I think one of the things that happens with drug abuse is the scenario keeps constantly changing. The principle of approach remains the same, but if you want to be a successful clinician, being able to manage addictions, we have to constantly update ourselves, and that includes me. And that's why I think, having these updates, talking about these situations, learning from each other continues to be very, very important. I want to thank you for a very patient hearing. I hope I haven't gone on too long. I might not have answered many of the specific questions that any of you have, but I think we can make that more of a discussion. I want to thank you for a very patient hearing, and I'd be happy to take any questions. Thank you very much.
Thank you so much, ma'am.
Thank you, ma'am.
To
Should I
chairperson.
start? Yeah. Thank you, ma'am. And firstly, I would like to congratulate ma'am on such an excellent talk and on actually a few areas. First of all, for keeping the underlying theme of musings in mind. I think musings is more focused on social issues, experiential issues, and psychological issues, and less on hardcore biology and psychopharmacology. So I think ma'am has actually done justice to this underlying theme of musings. Secondly, only an expert can actually speak without slides, and can actually touch upon so many different challenges. She's actually done an excellent job on touching. I don't know how the audience would react, but she's touched upon various issues and challenges in dealing with patients of addiction through her experiential journey, which itself is very heartening to know that she herself has gone through and understood and evolved as a clinician over the last, approximately 3 decades, right from initial understanding of addiction as a psychosocial, purely psychosocial or moral issue to now more of hardcore biology and genetics, of course. So she's touched upon many things, and I would not be able to enumerate on all of them, right from stigma, discrimination, the terminology used to talk about addicts and addiction themselves, the therapeutic relationships, the importance of a multiple team, right from social workers to psychologists to clinicians to even physicians, to the importance of therapeutic relationships with the patient and the doctor, and of course the other relationships that the patient faces. The importance of not focusing on abstinence as the only goal of the treatment of addiction, which is very important. And I think this is an important message that people have to take after listening to this talk, is that abstinence is one of the goals. The addict is, I'm sorry to use the word, the person who uses drugs, I think that's and I don't use the word addict at all now. The person who uses drugs is more than just the substance that he uses. It is very important to understand that the substance is only a part of his life. It is not his complete life itself. And that is where we sometimes make this mistake of just focusing on the substance, of whether he's taking, whether he's not taking, whether it's intoxication, treating withdrawal, and leave it at that. It is much more than that. And of course, the other challenges such as availability of treatments, the cost of treatment, the accessibility to treatment, so many such issues. So ma'am, I congratulate you on an excellent talk and by touching on various facets of the challenges of treatment of addiction. And I hand over to Dr. Gajendra for his own views on this.
Thank you.
Thank you, Dr. Singh. I think, ma'am, I must congratulate you for your beautiful insight into the journey of this addiction, and the way you presented from your own experience is something we'll learn from this presentation very much. Yes, ma'am. Regarding this one, there are challenges. There's so many challenges we come across while treating sort of addictive, so many different kind of addiction. I'll start with the treatment challenges. The first thing what we see is that treatment, how to start treatment, because there is so many new substances coming up in the market. We don't know many of these substances. For example, somebody has started ketamine now. You talk about inhalants, so many different things coming up in the market, especially in our place. See, since Imphal and this capital of Manipur is only 102 kilometers from the international border. So every day we come across so many different cases. So we never heard of how to treat that. That's one very important challenges we have. For example, if we want to start to opioid treatment, addictive treatment, how you detox, that's the challenges. Only in the government setup, we have this buprenorphine 0.4 milligrams available, not 2 milligrams in fact. So how to start detox program? That initial 14 days or maybe 10 days. That's the one challenges we see. We try so many other medications, pharmacological treatments like traumatic we start with, we try to eat what you call painkillers, but this is not sufficient to treat the initial part of addictions. So that's, I think, very important challenges in practically we are facing, not only here, different parts of the country. So we don't know the proper how to treat the patients, except buprenorphine. That's very important. This is one challenges we see. Then other challenges we see is that treatment of comorbidities. For example, cannabis. There's so many comorbidities with the cannabis. In fact, we don't know many cases. Like, is it because of the cannabis, there's psychosis, or is it because of underlying psychosis that is cannabis symptom? So these are different challenges we come across. That's, I personally feel that's a very important area to discuss with. Then other issues that inhalant treatments, inhalation. There's so many new inhalants are available. Then the amphetamine group of drugs are available now in the market, as ma'am you mentioned. Like in our place, we have what you call Yaba, then World is Yours, WY, so many different inhalants and or what you call newer substances available, amphetamine group of drugs. Then how to detox that? That's another issue. We don't have proper training on that. We don't know how to begin with that training. That's another issue. I'd like to focus on that, ma'am. Then after that, once detox program is over, like 14 days or 15 days, patient is almost pain-free. That initial withdrawal phase is over. Then how to continue that? Because patients still have withdrawal features, some kind of protected kind of withdrawals, joint pain, everything. So we need to continue our treatment programs, not only pharmacotherapy, but also what we call psychosocial therapy. That's, I think, very important issue that we need to focus on treating this opioid dependence treatment. Another important issue now coming up is that treatment with the young adolescents and children. What we're seeing nowadays is that when we started in 2003 as a addiction, what you call psychiatrist, whatever, in my place, that time I don't see so many cases now. But last 2 decades, what I'm seeing that there are sea change in that what you call age of onset of the addiction initiation. Like one that IPV happened in 2005, I was one of that co-investigator. What we see that at that time, the initiation of oral intake and injecting, the gap was almost 3-4 years. Now people have started without oral, what you call staging or oral intake, they directly jump to the injecting practice. Like people who inject drugs, they started injecting drugs first. That's one of the challenges we have. So treatment-wise, we have these challenges. How to what we call start treatment for that adolescents, also women. Nowadays, many of the women in my place, they started alcohol consumption. They come with that withdrawal features that they like to come to the government setup. That's another issue. Challenges, ma'am, I personally see in treating addiction patients. Then right after this treatment challenges, then how to rehabilitate this. Once patient is okay, then with the counseling, medical treatment, then challenges are how to rehabilitate these patients. So I see many relapses after this period, after initial detoxification. One of the reasons that how they go back to that previous situations. Parents, as ma'am, you mentioned that parents wants total abstinence. That's not happened in many of the cases. That case, again, they say that patient or parents don't trust us. We are sober for last so many days, maybe weeks or months, but our parents are not trusting us. That's one of the clues or what you call reason that they start again relapse. There's a different challenges I see come across here. Mainly problems that there is not many people who can treat addiction what you call patients, because they don't have what you call that GIL or that what you call they don't have that one. Many of our friends in psychiatrists, maybe they don't like to work on the addiction program. So though we have many psychiatrists, there is little psychiatrists who can usually interested in addiction program. That's another challenges I personally feel in my place. Ma'am, this is small, this thing, what I do as a this thing, psychiatrist treating these patients. Thank you, ma'am. Thank you.
Dr. Singh. Thank you for those very valuable insights. And I think there is really no getting away from it, that it's a very difficult problem to deal with. I mean, I think, as I mentioned, I think the ground realities are always there. So, I mean, I'm just going to give you some generic approaches that might be, something that we can all use in terms of, I mean, for example, you said that about newer drugs. Absolutely. I mean, in fact, when I was a student, the kind of things that you needed to know and what you need to know now is such a sea change. As you mentioned, all the synthetic drugs, the yaba, the stimulants, they're all extremely new to even to us, ketamine abuse of buprenorphine itself, all these are new problems. One of the ways I have tried to understand is really learning from patients and getting them to experience the effects of the drug, the side effects of the drug, what happens in overdose, and then try and classify the drugs into the various categories. And I don't think the categories, I mean, I think what we know are the categories of drug use more or less covers a wide majority of the drugs. So whether does the drug have a sedative effect? Does the drug have a stimulant effect? Does the drug have a hallucinogenic effect? Does the drug have a psychotomimetic effect? If you understand the broad principles of the effect of the drug, what happens in intoxication, what happens in withdrawal, then perhaps treating the withdrawal symptomatically is something that's possible. Of course, that's one of the reasons at our center we started the toxicology laboratory, and that I can tell you has made a sea change. We pick up so many compounds that we did not know people were using before. I mean, a typical example I can tell you is that, people were going and paying 20 rupees, no, it was 100 rupees per tablet, to one of the sites in the city to get their husbands off alcohol. And then the woman brought us, and they were spending thousands of rupees towards this. Then the woman actually brought us the substance, and because we have a toxicology lab, we checked it out. It was disulfiram. The cost of disulfiram is just a couple of rupees, and people were paying 70, 80 times that money to get that. So I think where our toxicology lab has helped is really to be able to pick up these kind of drugs, and therefore, and also monitor. You mentioned cannabis-induced psychotic disorders. Now in cannabis-induced psychotic disorder, actually, as the cannabis levels wear down, the psychosis also, reduces and it melts down. But you need to be able to have a resource to actually monitor them. Otherwise, you will end up giving them antipsychotics. If you don't have a choice to do a drug testing, you will obviously have to treat them symptomatically, but you'll have to follow them up to make sure that they are, that you can discontinue the antipsychotics after a particular period of time. We also know that in young people, and that's an experience, again, just through clinical observation, lots of young people who start cannabis in their early teenage years, if you follow them up, quite a substantial number of them actually convert to schizophrenia, especially if they have a family history of schizophrenia. So I think clinical evaluations, understanding the broad classification of drugs, following up patients is very important. The second very important thing is to really have the state-of-the-art treatment that's available, at least in terms of drug testing, in terms of the specific pharmacotherapy. But we do know that, colleagues earlier, when buprenorphine was not available, were treating their patients with clonidine with varying success. Again, I think buprenorphine as a medication has been extremely useful for patients, both in the treatment of withdrawal as well as in terms of OST for reducing the risk of injecting drug use, mortality from that, and they're able to be stabilizing. You also mentioned children and adolescents, and rightly so. I mean, it's so difficult to, when you get a child who's just about 12 or 13 who's using substances and, going to go into a career in substances. And therefore, when we work with these kids, we also become aware of the need not just to look at the demand aspect of things, but also to look at larger policies in the country and try and see, which is what colleagues who work in child and adolescent psychiatry are trying to do, to look at reducing the accessibility to drugs, but more importantly, trying to identify kids who are at high risk, kids of substance using parents, kids who have temperamental difficulties, kids who have academic difficulties, kids who have intellectual difficulties can also turn to drug use if they're in a peer group which has drug users. And finally, you mentioned women. Of course, I mean, I think the two things are happening. One is what is called a cohort effect with substance use. That is, over successive decades, younger and younger people are starting to use drugs. The second thing is, again, amongst women. And amongst women especially, there are even more barriers to, getting treatment, coming into hospital, mainly because who are the people who stigmatize these women? Sometimes it's health professionals like ourselves. And that's what we found. I mean, we work in a de-addiction center, in a psychiatric institution, and the women who came to us said that they perceive a lot of stigma and, looking down upon. So you can only imagine that if a sensitized group, there's a perception like that. In a non-sensitized group, the perception is far more. So I think we have a long way to go in making people understand that if they have an addiction, they need to reach out to get help, that they should not turn to drugs to deal with their, and I think that's where the larger public health intervention needs to occur, that people have now, drug use is something that's become normalized in many communities, especially to cope with various kinds of stress. And I think we need to work with people to get them, call it life skills, call it what have you, to really get them to see that substances are not a way to cope with stress. And I think that's a long period. I know, for example, people like Ashish Sheth in Mumbai are working with the Rotary, to look at schools, to look at actually trying to get children develop a positive mental health approach, and also, the saying no to drugs and not going towards drugs and getting help in the early phases. So these are things that are, but it's pretty, worrisome what's happening in terms of the younger age of onset and the gender changes in substance use. So you've highlighted very, very important challenges. We don't have answers to all of it. We just know a general approach to it.
Thank you, ma'am. Thank you so much.
Thank you, ma'am. Myself and Amrit will post small questions to you. Amrit, would you like to start, or I can go ahead?
You start.
Yeah, ma'am. In your talk, said that with reference to the biology. So suppose initially it is pleasure seeking, later it becomes misery fleeing, and the person is addicted to a substance. Now, many people say that addiction can't be cured. You can just replace one addictant with another more socially appropriate thing. So your take on this. So how are we replacing the addictions by a more socially, ethically appropriate ones, depending on the society that we live in? So this approach, what is your take?
I think in a large majority of people, in about 3/4 of the people, if you take the drug out, you teach people to deal with the craving and with the what causes the relapse. You also teach them ways of dealing with boredom, with anger management, with thing. There are several patients who are testimony to this, that they'll be all right, that they will recover, and there's lots of people like that. There is a small group of people who, there isn't anything like an addictive personality as such, but then there have been studies which suggest that they have, a very strong genetic vulnerability. They, as I mentioned, a lot of temperamental difficulties. They switch from one thing to another, maybe from a chemical addiction to a behavioral addiction. In those people, you probably have to look at, what is less destructive to them, what is less problematic to them, and help them along. I think the final challenge is not to replace the addiction, but really to make them more adaptable, and I think that is the challenge, to really find the ways in making them adaptable in society. That's as much as you can do. And believe you me, we think that, it's going to be devastating, but if you support them through this, many of them find their levels and they move on. I've had people now whom I've probably been seeing for 35, 40 years, I have lost patients. I have lost patients, of course. Several of them have given up their substance and had problems and passed away. Some of them, like you mentioned, initially they gave up their alcohol, but at that time we did not know that we had to do more aggressive things for tobacco cessation. So I had a patient who died of a CA lung, but had kept in touch with me right through. So all kinds of things. So we've had patients, of course, and I've actually seen premature mortality with the use of substances, and people have not been able to give them up. Now we are helping their families. We're helping the next generation. At least we're catching the next generation early and hoping that we can turn them around and make sure that they lead, their longevity improves, but their quality of life improves. I think that those are the most important things.
There's a question in the chat box, and it is a very practical thing. A person, one of my colleagues has posted it. They are practicing in a suburb area. So they said that we cannot give more than 5 minutes to the patient. And whatever approaches we are talking about, these are long-term, probably lifelong interventions. So how should a person sitting in a single OPD in a small town go about it? How can he help the person?
Okay. So if you divide all people with substance use problems into those traffic light things, you probably brief intervention may help a proportion of your patients. And that's been proven, for example, in tobacco dependence, as well as in other substance abuse, the brief interventions help a proportion of patients. But it has also been shown that more frequent interventions, repeated doses of interventions, longer duration of interventions produce more lasting change. So this is available to you. I mean, I think as psychiatrists, we need to spend, we can tell our physician friends or people who are working in general medical OPDs who have huge things, at least to do a brief intervention. But as psychiatrists, perhaps if we spend a little bit more time, or if we're not able to do it ourselves, get a group of people who will spend that time. That the time and attention can translate into better recovery.
Thank you.
Can I add something, ma'am? Just just a couple of sentences. I've seen many of the times patients do not get adequate pharmacotherapy, especially with busy practitioners who have just a few minutes to spend with each patient. And they don't get anti-craving medications, forget about buprenorphine or OST or other things. And I think it's very, very important that if you don't have enough time, at least treat the patient adequately. Give them enough doses of medication so that they're able to control their cravings. Say, for example, alcohol. We are seeing many patients who don't receive naltrexone, topiramate, baclofen, ecamprosate, and they're just given some benzodiazepines for a few days and they're expected to just come back abstinent. That doesn't work. So I think for busy practitioners, it's very important for them to educate themselves about all the anti-craving medications available, all the tools that are available to them, and use them adequately for a reasonable period of time in therapeutic doses. And that would go a long way, at least in a small proportion of patients who might get help and they will probably leave their substance. Thank you.
Yeah, I mean, I think pharmacotherapy has really helped in so many different substance use conditions. And I think if used properly in the right kind of doses, very important. But you need to spend that time to even decide what pharmacotherapy to give the patient and to follow up, because pharmacotherapy works if patients take it. And that's why you need to engage patients to make sure that what you give works.
And actually, time is the crisis, because a person sitting in smaller towns sees around 200 patients in a day. Some people see 300 patients in a day. So there is no time. So what we can do when there is no time? I think they can keep a support staff. I think that would be the most.
I think that's important. I mean, if you're so busy and you can't do it yourself, just make sure somebody explains to them. See, I find one of the most important things that need to be done, and sometimes our resident does it, or sometimes the nursing staff do it, which is really explaining that you take it properly, and come back if there are any side effects. So I think that explanation is very important, because finally it's about getting your patient to get an experience of success.
Amrit, you are craving to get in. Amrit, Please get over your
No,
craving.
I'm
I
not
mean,
busy. I have a query for Madam. Madam, a reason, I don't know if it's an excuse or a reason, many of my clients talk about for a relapses, they tell that there is excessive surveillance, excessive vigilance, you know, that makes them, sometimes compels them to take substance. So what happens is they come out of rehab, they come out of treatment, you know, it's a very dicey situation. If the guardians don't keep an eye, they do something. And there is excessive, suspicion every time they go out, even, just to have a glass of water or a cold drink, they're being checked. They're not allowed to close their rooms, So the index of suspicion is so high that they become frustrated and then they relax. How do we deal with such situation?
Yeah, I mean, it's the same thing that we talk about expressed emotions and other conditions. I mean, I think extreme degree of over involvement and is something that families do, and I think in some ways families are probably the most in some ways I don't want to call them victims, that's a very strong word, but they receive the brunt of it. But very often these are what are called enabling behaviors, excessive vigilance, simply fault finding, smelling people's mouth when they come in. And surely enough, that causes a lot of emotional distress to the patient, and kind of say, hang it, somebody doesn't trust me. So I think both the parties need to be worked on, mostly the families, to say that this has not helped. This actually worsens the situation, that you have to work on some degree of mutually agreed upon behaviors. Also work with the patient to get them not to respond to each of these things because they need to do that. But I think both these things need to be done. But you're right, that's a very, very important reason patients talk about. And it's very important to get families to kind of separate themselves a little bit and not to do that kind of spectatoring when it comes to people recovering from addiction. So explaining to them the in some ways the biology of addiction, the fact that there might be relapses, not to worry so much. I think supportive families, in fact, that's another example that I had, that if the family members are supportive, if the spouse is supportive and understands it, it's amazing what kind of change can occur with the patient. So I think working with families, not only to support them, but also to kind of teach them how to deal with the substance user is equally important. Thanks for flagging that. That's very important.
Yeah. Ma'am, once a few times I explained the biological model, and once I got feedback that now since I'm biologically handicapped or biologically sort of not well, so I should be given concessions. Why are you after me? So I should be given concession exams and things like that coming. So how to take care of this?
So that's what I said. No, I mean, although we know that there is a genetic basis, we also know that there is a ability of the individual to change. So and that is why, and too much of an overemphasis on the biology can be counterproductive in a therapeutic line. So even though you say that, this is what causes addiction, the fact that you can learn ways of handling craving, of handling emotions, of handling situations, I think that ability to learn is there. Now, when it comes to concessions, unfortunately, nobody gives concession to addictions. You can't get a liver transplant if you don't stop your addiction. So it's as bad as that. So, I mean, I think there's no way, at least so far in society, that people have really equated alcoholic liver disease and, let's say, some other cause for liver disease. People with alcohol liver disease have even a greater responsibility. It's very funny because you say it's a disease and then you expect them to have complete control, but that's the way it is.
So ma'am, can we tell them that your biology also dictates that you can change yourself?
Look, I would give the example of diabetes. Even in diabetes, just taking an anti-diabetic medication by itself is not enough. You have to make lifestyle changes, and there are people with the right exercise, with the right kind of diet, can lower their dose of diabetic medication. Or there are people who've controlled it so well that if they're on the borderline diabetes, they're able to do so without medication. And I think that's a useful analogy to give them. And that's why I talked about multimorbidities, that when all diseases which are non-communicable diseases usually have a lot of lifestyle regulation around them. And I think that is the thing that you could use to get people to engage and say, all right, I can make these changes and I can get better.
Amrit.
Yeah. Madam, there's a question from one of my colleagues. What is the best way to deal with addiction patients who have comorbid personality disorders? Especially if you have, in cases of male, we have antisocial, and in females, we have impulsive type. So what is the best approach?
Okay, so one of the things that I have discovered over time is that antisocial personality disorder with substance use is something that's overdiagnosed. It's very difficult to really differentiate the behavior that is a result of intense craving, for example, stealing monies, taking away things, because they have such a severe craving. It is a lot of that behavior is around the addiction itself. So I think that's important. Emotional instability, the other temperamental difficulties, as I mentioned, whether it's anger management, whether it's over idealization and de-evaluation, those are all very, very common in people with substance use. Difficulty in sustaining attention, wanting immediate gratification, the other border, maybe emotionally unstable trait. So many of them respond excellently to psychotherapeutic interventions. Whether it's some, it could be mindfulness, it could be dyadic, therapies, it could be just long-term supportive work. They respond to that. Of course, if they have other comorbidities of significant nature, they may need antidepressants, they may need mood stabilizers. But the most important thing is to work with the patient so that you understand, through. And sometimes it takes 3 to 6 months to really understand what is the underlying problem, because unless they stop their addiction, you can't even see what the underlying problem is. So helping them with their addiction, looking at the underlying problem, and then addressing that, you can actually turn around a fair number of people. You'd be surprised how many people you can actually help if you do it systematically.
Yeah, ma'am, there are questions in the chat box. So I reframe the question slightly regarding Alcohol Anonymous and group therapy. So what is their status in the management of these behaviors, and what is their status in India in our place? Because A is doing well outside here, and what is the status here?
A general principle is whatever works must be advocated as long as it does not have side effects. Okay, so I think psychosocial supports of all kinds are very important. Why Alcoholics Anonymous is extremely popular in many parts of our country. So, and there are people who certainly do well with going to Alcoholics Anonymous meetings. The principles of Alcoholics Anonymous are extremely sound principles, and they're very, very good, life lessons to patients. So I think the important thing is it requires a certain amount of motivation to go for 90 Alcohol Anonymous meetings. And if you go for 90 Alcohol Anonymous meetings, you'll do well. But it's also very good because if you get a good peer there, if you get good peer support, if you get a good, mentor there, it can be also very, very useful as a therapeutic strategy. If somebody has an Alcoholics Anonymous place, the only problem was in the past, Alcoholics Anonymous would say you should not take any medication at all. And that was creating a problem. But over time, the Alcoholics Anonymous have themselves modified by saying they do not pass judgment on other treatments. They only know that coming to the fellowship, etc., helps them. So many of them also take medication, come and see us, but also help others in their peers. So if that is the case, it can be a very, very useful, help, because especially when a lot of people need, everybody practically needs extra treatment support. And Alcoholics Anonymous, other peer support groups are very important extra treatment supports that you yourself cannot provide.
I mean, group therapy?
Group therapy as well. I mean, group therapy works very well if you can get a group together. Now, the challenges are to really get a group, especially group therapies work beautifully inpatient when you have, people there who don't have anywhere else to go. But in the outpatient, it's very challenging. Especially among young people, group therapies can be very, very effective. So all the psychosocial interventions, group therapy, family therapy, Alcoholics Anonymous, all of them have their place in the treatment.
If we have a Zoom group therapy, would it work? Just as
Looks
we are
like,
meeting.
looks like more and more people are trying it. There is a lot of research on both individual and group therapies online with positive results. So I certainly something to be tried. But again, the challenge of getting people together is really the main thing. But why not?
Amrit.
Madam, another challenge which I face nowadays in my clinical practice, though I'm no expert in addiction, but I see a lot of people who have these problems are the young, educated mass, madam. They talk about cannabis as if it is some elixir of life. They talk, they talk
Yeah.
about increase in their concentration, focus. They don't get caught in the hospitals. Even if there is a checking, they can easily hide it. It's easily available, cheap, everything, and there's so many literatures. Even Alim in his last 30 years has not read that much of literature. They talk about cannabis with all evidence. You have nothing sometimes. What do we do? How do we roll with this resistance in these patients? Another question was there. You have empathy, but then how do you roll with this resistance when it comes to cannabis, madam? Because the evidence about their bad effects or their side effects or their harmful effects are not very clear. So if it is alcohol, we talk about liver, we talk about X, we talk about driving and all. If it is opioids, we talk about the withdrawals. But when it comes to cannabis, we have nothing to talk about. How do we go about, madam?
Okay, yeah, I mean, and that's true of all drugs. Not just cannabis, it just happens to be topical now. But lots of drugs, people have, go on read on the net about this possible benefit, that possible benefit, and so on. Now, I'm going to tell you two stories here. One is, one thought that this is an example that was given by one of the researchers on cannabis from Canada. So she said in her study that this guy, they were doing some experimental studies with cannabis, and one included simulated driving on the highway. So here was this person, had taken cannabis, was driving at 20 kilometers per hour, steadily on the road. So many people in the audience asked, but he's driving so carefully. The lady's response was, in a highway where the minimum speed is 60 kilometers per hour, if you drive at 20 kilometers per hour, you cause an accident. So in fact, the research is actually looking at those aspects. And last month, I just reviewed for the WHO an association of cannabis and non-communicable diseases. So there will be lots of, it's not only young people, it is also professionals. Lots of professionals who say, hey, what's the harm in cannabis? Now, that's what started with alcohol. That's what started with nicotine. When you have a larger group of people who are using it, the likelihood, I think all of you knows the Rose's paradox and things like that, the likelihood of people having problems will also increase. Okay. So, and for example, in psychiatric institutions, and I have an interest in history, and if you look at some of the records from the early 20th century, in the 1920s and so on, you get a fair amount of insanity with hashish. You talk to colleagues from Tezpur or from Manipur, etc. You have a lot of people coming with cannabis-induced psychosis. I had a young lecturer who used to do a little cannabis now and then without any problems, went to Goa and came back starkly mad. She was hallucinating, she was going to jump off her balcony, etc. She had a potent form of cannabis which induced a psychotic episode. So that's the whole problem with any intoxicant, whether it's alcohol, whether it's nicotine, whether it's cannabis. The problem is that initially some use, occasional use does not seem to be a problem. But when you look at the way it kind of evolves, there are likely to be problems. So the main thing I think is to personalize risk, is not to talk about statistics, but in an individual, for example. And many young people have come with anxiety, with a bad trip, with something like that. So dealing with that. And second thing is, why did they need to use the substance? And trying to see if there are other ways of dealing with the substance. I mean, after all, giving a substance too much importance is also not a good idea. And that may work, that may not work. I mean, I think it's our responsibility as psychiatrists to give them that information, to personalize the risk and to tell them. And then to also tell them that, they need to get back if they have trouble. Beyond that, I mean, I think it would be very unrealistic of, of us being able to do beyond that. So I think we also need to know in the limits of our influence. But as a psychiatrist, I think informing them about the negative consequences is an important responsibility that we have.
And ma'am, what to do about this behavioral addictions and social media addiction, and what is your take on this?
The approaches, I mean, now more and more we know that the approaches to some of these addictions, the general principles of approach are the same. Explaining, establishing a therapeutic alliance, looking for comorbidities, trying to control screen time, making a plan of action, looking at underlying problems, particularly behavioral addiction, looking at anxiety, particularly social anxiety, looking at personality related issues. Those are the approaches. And of course, making sure that the person does not switch from one addiction to another, point that you mentioned. Those are the broad principles. But in society, that's another thing. You know, these kind of problems keep shifting from one thing to another. So I think looking at the underlying determinants of these problems, these are the so-called epiphenomena, drug use or racing or gambling, are the epiphenomena of an underlying problem. And if we understand that we need to look at what is the underlying problem and help people cope with some of these things, perhaps their need to turn to either a substance or to a behavior can be reduced to some extent.
How far has technology advanced in this case? Suppose are there any apps to monitor our behavior? So what is the role of AI, all this technology inputs in this field of behavior?
Tremendous. I mean, I think there are hundreds of apps now for smoking cessation. Hundreds, not just one or two. And similarly, the WHO has developed an app right now. So I think the use of AI and the use of apps on one hand is definitely helping people. Again, it's about help, allowing people to help themselves and to develop their own mechanisms, I think, on one hand. But we're also aware that I do not know what's going to happen. And, COVID has brought in a time where it's been very exciting to use technology more and more and more. But just before COVID, remember, we were talking about technology addiction as well. So the problem with things like technology is that they have a huge use. We do not know when that use can become misuse and lead to an addiction to technology. So that's a challenge.
How do these apps work in reality?
How are
these apps working?
How are the apps working? There is established research that some of them have been very useful and possibly have good outcome rates. Oh, but then a lot of the apps also, we find that people don't use them enough, and it's not useful for everybody. Again, depending upon the extent of your addiction, we talked about the orange, green, and red zones. It may not be useful for everybody. In addition to apps, there is also, for example, for tobacco, there is M cessation, where you just have to give a missed call to 2217091, and you will get SMS messages on the importance of stopping tobacco, how to stop it, how to prepare yourself, how to quit, how to stay quit, and so on. There are tobacco quit lines where you call a quit line number. You can get a counselor to quit you. Similarly, there are things for drug abuse. There are various kinds of things that are available, but the problem is huge. So,
excuse me.
Yes, sir.
As you mentioned about M cessation, which is around 4 years old, I think.
Yeah.
It was also promoted by the government of India. Do we have any long-term success rate of M cessation? Because there are many reports after 4 months, 1 year, and after 4 years, 2 years.
No.
What has happened to the?
No, there are none of those long term. But the way of looking at it is in public health interventions. Short-term outcomes are very, very important. It's unlikely that they will result in. Unless you have milder forms, and milder forms of addiction, possibly that might work. Nobody has looked at it in the long run, but I think there are tremendous advantages even in the short term with these public health interventions. So I think while it will be very good to have long term things, I don't think that is the objective of these these interventions, because even in the short term they are very good interventions.
I think 1 or 2 questions are about how ADHD and substance abuse, madam.
Yeah.
So I think Dr. Ashok Kumar has asked that question. Yeah, I mean, I think more and more people are understanding that, you know, they can either be an axis 1 comorbidity or a personality related issue, and amongst them, childhood ADHD, adult ADHD are commonly recognized, and they if they're recognized properly, and there are treatments available for that, and with those treatments as well as with anti-craving medication, as Ashwin mentioned, with the appropriate kind of pharmacotherapy, these patients can definitely be helped.
Another interesting question, madam. Dr. Satyan has asked, madam, what are the goals of treatment which you use in patients of substance abuse? I think that's a very, very important thing.
Yeah, absolutely.
What are the goals?
Yeah. So one of the things we do is make the goals with the patient. Once you've had a session with the patient, you determine goals. And, very ironically enough, most patients say abstinence. And I think that's the priming that has occurred with everybody. So, so of course, then, then you kind of say, okay, we'll work with that, but don't worry, even if you can't abstain, I know, let's look at trying to reduce the problems from it. Let's look at reducing the drug use and work towards abstinence. So setting the goal, yes. The important thing is that you don't prescribe goals without a discussion about the nature of the problem. So you kind of gently get the patient to, to determine the goals, and invariably, very often they decide, okay, we want to stop, we're tired of it, I'm tired of the family is tired of it, I want to be a good role model to my family, etc., etc. So that is what is called change talk. The moment the patient engages in change talk, it's the, so that we do what is called a stock taking. What are the good things about taking the substance? Patients are often zapped and saying, what is this doctor asking us about the good things? Then you explain to them, look, you wouldn't have been indulging in this, spending money, if there wasn't some positive effects that you got. So you discuss the positive, very often temporary effects of feeling good, of reducing anxiety, of getting all the troubles out of your head, etc. And then you talk to them about the potential adverse consequences, the not so good things about taking drugs. What are the good things about stopping drug use? And what are the fears about stopping drug use? So you have a nice little grid of some advantages, more disadvantages of taking the drug, some disadvantages of stopping, but huge advantages of stopping. And that's how you move the patient from a stage of not considering change to a stage of, oh, there are positives for me, but I'm afraid. I'm afraid of losing friends. I'm afraid of what will I do when I feel desperate or lonely? What do I do? And then you say, okay, let's discuss ways of supporting you to deal with this. So you don't need to use drugs to deal with this.
Yeah, ma'am. Last question from my side. Talking about nicotine, not cigarettes. Talking about the gutka. Many people come to me and they say, "Ki, sir, inka gutka choda dijiye." So how do I go about it?
So gutka actually is banned in most states in the country, but as we all know, when there is a demand, it becomes available, or people mix their tambaku with the with the non-nicotine thing. Gutka is the same. I mean, it produces nicotine. So the same principles of tobacco cessation that apply for cigarettes apply for tobacco, for gutka as well. Of course, with NRT, you have to be, so sometimes we use bupropion for smokeless tobacco addiction. If you use NRT, generally they don't, smokeless tobacco users do not tolerate the levels of NRT that you use in cigarette smokers or BD smokers. So you have to use far less NRT. Okay. In fact, we've had better outcomes with smokeless tobacco users because probably unlike smokers, they don't produce those rapid ups and downs in nicotine. So good, counseling, small doses of NRT or bupropion can help in smokeless tobacco use. Naltrexone it's not cost effective to use naltrexone in smokeless tobacco, and I think the results haven't been great with naltrexone.
Alim, we have troubled madam for far too long. The last question I will ask and will not expect madam. Wait, Alim, let me ask now. So there's a very interesting
okay. I'm just laughing because of the conversation we had at the beginning of the last and the ekdam
somebody madam has asked about tell something on sex addiction, please. I don't know what she expects. Maybe we will have to do another musings on this.
On that, yeah.
So we will not take this question this time. Maybe we will. Alim, this is another topic for us we can take. It will help you also. So with this, I hand it over to the chairpersons with the concluding remarks, and Dr. Tufan sir, if he wants to ask any questions.
Thank you so much, ma'am, for this very interesting and enlightening presentation. I just have just a few couple of probably take-home messages. First, very importantly, is that there is no one size fits all. I think you have to individualize treatment. One. Two is that look beyond the substance. It is very, very important to try and find out the vulnerabilities and comorbidities, and please treat those as much as you want to treat the addiction itself. Third, please remember to build a therapeutic relationship with the person. It goes much more beyond than just the abstinence part of it. It helps in the recovery of the person himself or herself. Very important. And fourth, last, is that please use all the tools that you have at your disposal. It is very, very important that you just do not focus on one aspect of treatment itself, but you are able to use both pharmacology and psychosocial interventions as best as you can in your context. And I think these are the four very important messages that people must take before leaving this very, very important session. Thank you.
From my side, ma'am, the take-home message will be like, before setting up the goal, I think we should involve that, we should talk to the person concerned, and involvement of close family members, especially parents, significant others is very important. Then we can sit together and set up a goal. That's very important. Then second important take-home message, I suppose that trust by the family members. That's a very important one, the cause of relapse. Trusting. If there is mistrust, there is again chances of relapse. So trusting by the parents, have some confidence in the parents is very important for cessation of drug use. There's a two important take-home messages, ma'am, from my side, from discussion with this August gathering. This is very important thing from my side.
And thank you to the organizers for the opportunity. Thank you so much.
I don't have any further question because it was exciting and highly enlightening talk by Dr. Murthy. And questions are reserved for the next session, which should have with Dr. Pratima Murthy. There are many possible questions. Actually, we do not deal with the gap that exists. People who need treatment and who the persons they reach, they don't know what to do. Majority, we are talking of the high centers, the busy practitioners who are surrounded and who are not distributed uniformly all over the country. But we have to think about the country for this problem. But we'll discuss. I have managed to the addiction centers from the 1980s, and I know the problems. There are a lot of problems, political, very many type of problems. Those things we can definitely would love to have another session with you. Thank you very much, Dr. Pratima Murthy.
Thank you very much, sir.
Thank you so much.
And I also thank Dr. Amrit will be proposing the vote of thanks. Yes, over to Amrit.
Just one line before we come to you. Ma'am, when we're talking, I got this recall that when children are growing up, they say कि अब बड़े होके क्या बनोगे? तो बोलते हैं doctor या engineer. So and there are many other professions. Then we talk about it. So in addiction, instead of talking about आप क्या करेंगे abstinence, instead of abstinence, there is a huge variety of goals that we need to address. I think that is my take-home point for today.
Good, Alim, you learned something today. Most of the time we are teaching everybody. So on behalf of Thursday Musings, I would, it's a formal thank you, madam. You're so good, you're brilliant. You actually, like Ashwin boss has summarized whatever I wanted to speak. Thank you so much for coming on your telephone call, madam. That's so nice and good. That speaks about how greatness makes somebody more humble. Thank you to two of my very close friends, Ashwin boss and Gajendra boss. Thank you so much for being brilliant. You took a lot of questions. You answered. You asked a lot of things which we had not even thought about. Ashwin was equipped in with his answers, with his experience. Thank you, Tufan sir. You have always been the guiding light, never interfering, always there. We know that you are there. We will not fall down. Thank you, our Thursday Musings team, including Shazia, who is not well, Sharda and Rucha. Thank you, IPS OSB, who have given us the platform, who has given us the green signal, and who have given us the accelerator to go however, whatsoever way we want to go. Thank you, Alim. Today, boss and Ashwin boss managed to keep you quiet, and I'm very, very happy for that. Generally, you are the person who speaks maximum. Thank you, everybody. Thank you, audience. We had, even in spite of the huge pandemic, and the last 1 week has been very, very terrible. In 7 days, last Thursday we were in a different mode. Today we are in an absolutely different mode.
Absolutely.
In spite of that, we have around 170 login. That's good enough, Alim. And thank you, everybody. Thank you for being patient hearing. Hope to see you again, madam. We hope to bring you back on our platform again. Thank you so much.
Thank you. Absolute pleasure. Bye-bye.
Pleasure for all of us.
Thank
Good
you.
night and stay safe.
Thank you, ma'am.
Thank you. Thank you so much. Good night, everybody. Happy weekend.
Thank you, Dr. Gajendra Singh. Thank you, Dr. Ashwini.
Thank you, sir.
Thank you, sir. Thank you. Thank you.
Thank you so
Good
Thank
night.
you.
Thank you.
It's
Good
so
night, sir.
nice being with you.
Good night, sir.
And we'll be closing down the meeting. Pawan.
Goodbye, everyone. See you
Bye.
next.
Bye.
Bye.